Hello and welcome to the NASGP podcast, The Art of GP Locoming, and I'm Dr. Richard Fieldhouse, and I'm joined today by Dr. Lisa Harrod-Rothwell. Welcome, Lisa.
Thank you for having me today.
So Lisa, you're joining us as you're currently newly appointed Chief Executive Officer of Londonwide LMCs. And I think today what we want to really do is just really talk about you and your career, both in you as what's brought you to be a practicing GP, and also your current roles, what's brought you to where you are now as in this position, and also maybe towards the end chat a bit more about sort of where we are going into the future in general practice, particularly in your expertise of working across 1,100 practices in London as CEO, and the future of the NHS. So why don't we start at the beginning then? So tell us about why what made you choose to be a GP?
I had a really positive experience of general practice when I was about 14. My grandmother was terminally ill, and it was a really difficult time for my family and for me. And the GP visited regularly during the end stage of my grandmother's life. And I remember the feeling of relief when she walked in through the door. She didn't even have to say anything. But it really felt as though we had somebody on our side who could address the problems that we were experiencing, who could offer us some support as well in a way that no one else could. So, when I decided I wanted to be a doctor, and then I had some career choices to make, and I started out in obstetrics, but then rapidly realised that it was the holistic side of care that I really enjoyed, and that led me into general practice.
Go on. And so where did that begin? Was that in London that you started your GP training?
My GP training in Essex. I'm
Oh,
an Essex girl.
are you now? Something to be proud of. Something to be proud of.
Absolutely.
And that when you did GP training, was it just the 1 year, or were you doing into 2 to 3 year training then?
Yes. So my training was extended because I just had my first child just before I went in, or just as I was starting my GP training. So I worked part time, which was actually quite unusual to do GP training part time back then. But it was a really good experience. Had a really positive experience of that, and so I did various different specialties that I hadn't had exposure to, and then did my GP registrar year.
And then once you qualified, did you what was the first role you went into?
I first started out as a locum, and got experience of different practices, but I really wanted to be settled and bedded in a practice. So it wasn't long after qualification that I went into my first salaried role, and I have been a salaried GP ever since. I have done bits of locuming um, now and then, but I have always stayed as a salaried GP.
And ever been tempted by a partnership at all?
I was. I was. When I first qualified as a GP, I was really interested in becoming a GP partner. I think in those days it was very difficult if you wanted to work part-time to get a partnership. I think things have changed obviously a lot since. Uh, so yeah, and then my career moved in different directions. So I ended up being more involved in NHS leadership, um, rather than going back to pursuing a partner position.
And you said when you did your GP training, you were doing that part-time, raising a family. Did that part-time work continue? Are you still part-time now, in terms of your portfolio? Do you still have a day or an afternoon off a week when you're not doing anything clinically related, or are you just now full-time GP, but it's broken down into different roles?
So I'm very much full time in my leadership role, whilst I still do weekly my weekly salaried job. But my children are now at an age where they definitely don't want to spend time with me. So the days of taking time off to really make the most of those years. Yes, my kids don't want to play ball with that anymore as teenagers.
Oh, but Sarah and I have found the same as well. As the kids have grown up and gone to university, it's sad in a way, but in other ways, it's quite nice. It's nice you kind of done your job, and they've now flown the nest, and you can be a bit more committed back to the job again, having done that part-time role. But you've also, just to throw things into the mix, you have worked at a very high strategic position in clinical commissioning groups, and even PCTs back in the day as well. How have you managed to mix all that with being a relatively newly qualified salary GP in a practice, and then taking on those big leadership roles?
So my leadership journey starts out at LMCs.
Oh,
So I was a part-time salaried GP, and I just returned from maternity leave, and I was finding my feet again, and I was finding it quite difficult as a mum coming back. I do remember the anxiety on the journey on the way in, thinking, "Do I know how to manage emergencies anymore?" Um, and 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 there were some things that were quite challenging about that period of my life, working as well as having very young children. And lying around in my practice was a letter from the chief exec of Essex LMCs encouraging salaried and locum GPs to get involved with local medical committees.
was that Brian Balmer?
It was,
Good,
yes.
Brian. We love Brian Balmer here at Maybe GPs.
Um,
Fantastic advocate for sessional GPs for years. But so he's done his magic on you as well. Wonderful.
that's how I started. So the letter was lying around and it said, if you're interested in getting involved and understanding more about the more strategic side of general practice and working to address some of the challenges of being a GP, um, and working effectively, give us a call. And I gave him a call, and I felt really nervous when I gave him a call. I remember that phone call. And he came on and he was very friendly and encouraging. And then I became an LMC rep. And it wasn't that many years after that we started to have the discussions about the new healthcare bill and the setting up of clinical commissioning groups. So this is probably around about 2010
Yeah, that rings.
time. And in most areas, there was already the infrastructure to take forward GP-led commissioning into clinical commissioning groups. But in my part of Essex, there wasn't. And so there was a bit of concern very, very early on about who was going to take this forward. And there was a very experienced, very encouraging GP on our local medical committee. You know how you have the kind of grandfathers or grandmothers of general practice in some areas, and he very much was that. And he really encouraged me to get involved with the PCT and um, and to be able to take this forwards. So I ended up being one of very few, if um, female part-time salaried GPs to take forwards the clinical commissioning group development. And so I became PCT Director of Commissioning, I think from about 2010. And then the CCG chair from 2012 when they became established. So it was a fantastic opportunity. It was the biggest learning of my life. I really was thrown in at the deep end, but I
There's all of that.
learned a huge amount.
Yeah. But you came up for it. I mean, what a journey. I love it that there's sort of a lingering letter from an LMC chief executive be trying to get sessional GPs involved. You saw that you've gone on, there's something about you, Lisa, that you felt that you didn't mind that challenge. You were key. I think you said you were coming in a bit of a vulnerable stage. You were a part-time mum just back into general practice, and you saw the connection between being in that position of vulnerability, but then actually having some sort of olive branch thing to hold on to that could bring you out of it, and you've just gone on and climbed the rest of the tree by the sounds of it. And with all your PCT, which is a precursor of CCG, isn't it? And then in those leadership roles. So this person then what when working in your CCG role, in your commissioning and work and in the LMC, what kind of what kind of things do you think that you're passionate about, that you've brought to this role and you've done something about it? I've heard before that you're very interested in the whole clinical safety aspect, safe working, and obviously continuity. So yeah, tell us a bit more about that.
So I'm really passionate about patient care. I'm really passionate about safe care, about effective care, about high quality care. And I'm really passionate about that holistic continuity of care that general practice brings. I think it's just so important to see people as a whole person and to see them in the context of their families and their local communities. The doctor as a drug, I don't think can be underestimated. And being a GP is really challenging, but it is so, so rewarding. So rewarding. Being invited into people's lives when they're at their most vulnerable. And all the way through my leadership career, I have really wanted to advocate for meeting the needs of patients, particularly health and addressing health inequalities. I'm working with the most vulnerable, where of course we add the most value, and really passionate about what general practice offers. And in recent years, it is utterly heartbreaking just how denigrated and misunderstood and undervalued general practice has become, because it really does add so much value.
You've one word I've heard you use before is the word relational practice, as in relationships, and that's kind of, to me, it's almost kind of one step above continuity. It's, you can have continuity, but continuity can sometimes be a bad thing. But good relationships are always good relationships, and that what your inspiration, that GP who attended your grandmother in her final days, that was about a relationship. Oh, well, as she was turning up regularly, there was continuity, but there was a good relationship you had with her, and you had trust and faith in her as well, I imagine. And that sounds like that's really come through to what you've been doing. And I've seen your work as well also on retention, because obviously you cover London. I mean, don't pick the easy targets, pick London, and you've got 1,100 practices across your patch. And I imagine the movement, the churn, the change of the recruitment and retention must be so fast paced and so fast moving, I guess, and to keep a stride on that. Tell me a bit more about safe working practice, because we've heard a lot about that with the BMA safe working conditions thing. Is that something that's a particular issue around London, the safe working limits?
I think safe working is an issue everywhere, and every area will have some particular challenges around safe working. And it is really important that GPs, irrespective of contractual status, whether they're salaried, locum, partners, that we all feel that we can go into work, that we can do a safe job, that we can do a good job. And obviously, as the finances have become more pressured, as there have been increasing cuts in services, as we've seen workload shift from other providers onto general practice, most GPs are now finding that a real struggle.
Mm.
And in fact, our last workforce survey, uh, the majority of GPs felt that because of those reasons, they were no longer able to practice safely. So we're doing a lot of work in addition to the BMA work around safe working, looking at what actually is within our contract and what sits with other people's contracts. And we have a number of resources and guidance to help GPs to understand that. I honestly believe that nobody in any provider, hospital or otherwise, sets out to push work our way that shouldn't be coming our way. But unfortunately, there is a lot of misunderstanding about what sits in which contract. And so we've got a lot of work to do, not just in advising and supporting GPs to be able to say no to things that are inappropriate, but also working with our system colleagues to help rebuild those relationships. So you're right. Actually, a lot of what I do is focused around relationships, but I am really keen that we build really effective relationships with our secondary care colleagues. You know, these are good people, and we liked them at medical school. We need to rebuild those relationships with them. We need to get a shared clinical understanding. We need to be able to have better conversations about patient care, because patient care is now so complex. We need to have a different model of care that, rather than involves pushing work either side of an interface, actually collaborates. So I'm really keen that we work with the system, particularly in light of the 10-year plan, to devise a clinical model for care that works for patients and also provides us with the best way to use our most precious resource, and our most precious resource is our workforce.
Yeah, absolutely, and I think in the GP workforce, I think traditionally, in hospital secondary care, the there are departments, there are constraints, there are highly defined, always have had to be highly defined. Are you going to be in surgical, or are you going to be in medical? Is that cardiac or is that respiratory? We've always worked within those very clearly defined definitions. Anything else outside that is general practice, and you're right. I think there it's it and it's like with naughty children. You don't blame the children, you blame the behaviour, and this behaviour isn't due to naughty doctors in hospital. It's just due to that behaviour we've had for many years, and it's just medicine is so complex, and defining exactly what a GP does is just really hard to do. It sort of sounds slightly obvious, but it's actually not. And yeah, and it's been the slow, pernicious. I can never work out boiling frogs or whatever, but you know what I mean. We've just slowly reached this point where we think, oh my god, this is just too much. So those safe working standards, I noticed this last year when in general practice, we started to become more cognizant of that and start to implement safe working in times and strict numbers of appointments. And it did I felt such a tangible difference to the people, to doctors, and not having to actually not feeling so guilty anymore for finishing at 6 o'clock, and being able to have that work-life balance. Um, so when you mentioned the 10-year plan then, so where that talk about something that's amorphous. I mean, how have you had time to think and reflect on the 10-year plan and how we're going to fit into that and how we can help shape it and how that's going to help us with safe practice and retention?
Mm. Absolutely.
I'm dying to hear what you're going to say.
So I think it's fair to say that the NHS moving forwards is not going to look like the NHS does today. And that's not necessarily a bad thing, because I think most of us working in it who go home most nights with moral injury would recognise that something needs to change. And I think that's probably fair to say of most patients as well. The 10-year plan is very aspirational. It doesn't talk a lot about how it's going to be delivered. In order to have major system change, there's going to need to be a significant program of development, and that needs resource, and there's no detail about that. So it's quite hard to look at what's been published so far and feel that we're clear of exactly where we're getting to, why, and how. Um, that said, there is always opportunity, and it's really important that senior decision makers recognize that if you want to find the answers to problems, you give those closest to the problem the responsibility for the solutions. So when we're looking at the future of healthcare, that means giving the responsibility for coming up with the solutions to the people delivering care in collaboration with those receiving the care. We know what's broken. We know what works. We know what doesn't work. We experience it on a day-by-day basis. Not only do the people closest to the problems need to be given the ability to come up with solutions, we also need to be given the headspace in our day-to-day work, because we need to collaborate across the system. We were talking about a clinical model. We need to look at the clinical model of care, and that means pulling in our mental health colleagues, our secondary care colleagues, our community colleagues. Let's understand what good care would look like. And when we've got that clinical model, give us the autonomy to be able to test and learn and refine. And then, and only then, put in place the contracts and the policies that enable the solutions to be implemented. What we've seen recently, in recent years, is a contract has come in, and the contract has driven a clinical model. And that doesn't work very well. We've got to start with function first. And I really do urge sessional colleagues, salaried locum colleagues, do get involved, because you will know a lot. You will have so much insight about what works and what doesn't work. Get involved with your local medical committee, wherever you are in the country. And if you're in London, in one of our 27 boroughs, contact me or reach out to your local medical committee, because your views do count. They're important. And we have this opportunity, and we need to grab it.
You should send one of those letters that Brian Balmer did. Send it to everyone's inbox, and they'll pick that up, and you'll get someone. And you genuinely mean that, don't you? You want people to call you like you call Brian, and you can talk them through. But this time, guys, don't feel nervous about speaking to Lisa like you felt nervous. You don't need to, do you? I think
Absolutely. And there may well be local GPs who you know really well who are sitting on your local medical committee. So there may be people who you've worked with before, or you've trained with, or were trained by, or who you know from a neighbouring practice. Um, because the way that we're structured is that we have our local medical committees in each borough, and then Londonwide LMCs sits across 27 boroughs. So either reach out to your local medical committee or reach out to us at Londonwide LMCs, because we would be absolutely delighted to hear from you.
brilliant, brilliant. The what you were just talking about just before, the having that giving those closest to the problem the responsibility, and then giving those people the autonomy. One thing I was waiting for you to say, and I think you said it, but I just want to make sure. But also, we're going to need to control as well, aren't we? I mean, I hate being made responsible for stuff that I can't control, and sometimes I feel in general practice they give us all the responsibility, but then they tell you, well, you did say this, they did with the contract, they then don't give you the control. You're saying we need that control as well.
I passionately believe in clinical autonomy. And yes, absolutely. So I being held accountable for things that are not within your control is just not tenable and not sustainable. And it is vital that those who are making the decisions are accountable for those decisions. And what we've been seeing nationally, particularly with the previous government, were decisions that were being made and promises that were being made that were undeliverable, and yet GPs were the ones held responsible for the failing. When every single provider is deemed to be failing It is not a failing provider. It is a systemic issue that needs addressing. So I absolutely believe that those making decisions need to be accountable. When we look at where the decisions should be made, they should be made closest to the problem. And when we look at practices embedded in local communities with the clinical autonomy to bespoke their services to meet local need is really important. And I know that the drive has been and continues to be this standardization and at scale services where everybody gets the same offer. As GPs, we know that won't work. As GPs, we know we have to change what we offer, how we interact. We need to take our management plans and put them in the context of that patient, their beliefs, the the family that they live in, the community that they live in. We need to make it holistic so that it really resonates with people and is acceptable to people. One size fits all will never work. And that's why it's really important that we maintain that autonomy at the very, very local level.
And that brings us full circle with your inspiration as a 14-year-old with that GP who you had that trust and that faith in, and we're in times of that autonomy when GPs were the people so closest to the problem and solving it.
Really, all levels, at all levels, whenever we look at the NHS, right from that personal interaction with the patient up to the way that the practice delivers services to local communities. And then when we start looking at neighbourhood working, how we work with different services, and then the more strategic conversations around funding distribution. But it all has to start with the clinical model. It all has to start with the function of what we're trying to achieve and how best do we do that.
That's fantastic. I think just I suppose just to finish and round off on then, Lisa, what how do you feel about the next, not 10 years, but next 5 years? How do you feel about, do you feel are you, do you wake up in the morning thinking, yippee, I can really do something here. We as GPs, we can do something. Are you feeling skeptical? Are you feeling anxious at all? Or all of the above? How is it? What's your, how are you when you get up in the morning?
I always think that in a leadership role, it's always really important to look for the opportunities and mitigate the threats. Um, in terms of the threats, I am concerned that the real value of local practice led delivery to local communities is misunderstood. I am concerned that the role is not highlighted within the 10-year plan. That worries me.
Mm.
That worries me because if we lose that really, really, really the real value of general practice and the characteristics of general practice, the job that we trained to do, then the patient outcomes will go down, patient satisfaction will go down, the financial efficiency of the NHS will go down. We will lose such a valuable role. So that does really, really concern me.
And our satisfaction will go down. And I think this is the reason why you're saying sessional GPs, salary GPs, GP locums out there. This is where where LMCs need you to join your LMCs and work with people like you in any part of the country to make sure that we are going to, we need to be factored in fundamentally into this next 10-year plan, not just not we mustn't be passive. We need to be active, and people like you with your experience, with your roles that you do working at the front line, those are totally invaluable experiences that we need.
Absolutely, absolutely. And the relationships we have with our patients are really, really, really important. So that's the threat side. There, of course, with any change, there's always opportunity, and I think that we have a very strong case for change. I think if the NHS and general practice and GPs all and patients all felt that nothing was broken, change wouldn't be appealing at all. But it's not like that. It's not like that at all. We know that GPs are really struggling. We know that they're leaving the profession. We know they have moral injury and burnout because they can't do the job they trained for. We know that they feel they're lacking in power. We know they feel they're accepting responsibility for other people's decisions. And we've seen the denigration that's happened of general practice. So there is a very, very, very strong case for change. And when we look at some of the opportunities, there's a big focus in the 10-year plan on at-scale working. Now, I think that there's opportunity in at-scale working, but it's not instead of practice-level delivery. It's alongside practice-level delivery, and this comes back to function before form. So if we're looking at that relationship-based family medicine, that's really local. If we're looking at a more specialized service, if we're looking at, for example, it might be insulin initiation, it might be a specialist, it might be a tier 2 neurology service, then we start thinking, what scale is it appropriate to deliver this at? And that will depend on the local population. Again, there's no one size fits all across every single part of the country. If you've got a high prevalence of disease, of a particular disease, you might need it at a really quite local, small scale. If there's a low prevalence, then you will need it at a larger scale. So again, no size fits all. But there is real opportunity, and we've got the opportunity to have GPs with extended roles. And so for those who are of my generation, what we used to call gypsies, to be able to potentially move into that space, to have breadth of career experience and career development. But as I say, that's not at the expense of the role of the GP and the role of the family doctor.
I think that's a really powerful note to end on, Lisa. Thank you so much for that. Really, really great pleasure to have you along today. And thank you everyone for tuning into this podcast. It will also be available on YouTube video. Do subscribe so you get regular updates. And thank you once again, Lisa. Take care.
Very much. Bye.